Good morning, students. Today we will see the differentiate part 3. The first one is hydatidform mole and ectopic pregnancy. Hydatidform mole, it is an abnormal condition of the placenta where there are partially degenerative and partially proliferative changes in the young chorionic villi. The HCG level is elevated. There are mainly two types, partial and complete. The main clinical features include vaginal bleeding, varying degree of abdominal pain, and expulsion of grape-like vesicle per vaginally. The main treatment include suction evacuation of the uterus and follow-up is mandatory. Ectopic pregnancy, it is the case in which the fertilized ovum is implanted and develops outside the uterine cavity. The triad of symptoms include short period of amenorrhea, vaginal bleeding, and abdominal pain. Mainly two types, the ruptured and unruptured. Medical treatment in case of unruptured with methotrexate and laparotomy in the case of ruptured cases. Amniocentesis and calidosynthesis. Amniocentesis, it is a deliberate puncture of the amniotic fluid sac per abdomen, preferably performed between 14 to 16 weeks. Root is abdominal. The main diagnostic indications are for diagnosis of chromosomal and genetic abnormality. Calidosynthesis, it is the procedure in which peritoneal fluid is obtained from the Caltech sac. Root is vaginal. Main indications are suspected ectopic pregnancy and suspected case of pelvic abscess. Postpartum blues and postpartum depression. Postpartum blues is a transient state of mental illness observed 4 to 5 days after delivery and lasts for few days. Nearly 50% of postpartum women suffer from this problem. Manifestations are depression, anxiety, tearfulness, insomnia, helplessness, and negative feeling toward the infant. No specific metabolic or endocrine abnormalities have been detected, but lowered tryptophan level is observed. It suggests altered neurotransmitter function. Treatment is reassurance and psychological support by the family members. Postpartum depression, it is observed nearly 10 to 20% of mothers. It is more gradual onset over first 4 to 6 months following delivery or abortion. Changes in the hypothalamic pituitary adrenal axis may be the cause, manifested by loss of energy and appetite, insomnia, social withdrawal, irritability, and even suicidal attitude. Risk of reoccurrence in the subsequent pregnancy. The treatment is serotonin and uptake inhibitors. Molding and Chignon. Molding is an extent of overlapping fetal skull bone is called molding, and it can produce pointed or flattened shape to the baby's head when it is born. Normal variations in molding of newborn skull, which is usually disappears within 1 to 3 days after the birth. The bones of a newborn baby's skull are soft and flexible with the gaps between plates of the bone. A chignon is the temporary swelling left on an infant's head after ventral suction cap has been used to deliver him or her. It is not a sign of serious injury and may take as little as 2 hours or as long as 2 weeks to disappear. Then apart from postpartum depression and postpartum blues, one more term, that is postpartum psychosis. It is observed in 0.14 to 0.26% of mothers, commonly seen in women with past history of psychosis or with a positive family history. Onset is sudden, usually within 4 days of delivery. Manifested by fear, restlessness, confusion, followed by hallucinations, delusions, and disorientation. Psychotic women may have delusion. Suicidal, infanticide impulse may be present. Management be by psychiatric consultation and hospitalization. Breastfeeding is contraindicated in case of lithium medications. Retroversion and inversion. Retroversion, it is neither congenital or acquired, considered as a normal variant of uterine position. In majority, the spontaneous rectification occurs as the uterus grows. In minority, spontaneous rectification fails and uterus becomes incarcerated in the pelvic cavity. Effects on pregnancy include abortion, increased chance of malpresentation, non-engagement of head, and rupture of uterus during labor. Inversion is an extremely rare and life-threatening complication of third stage of labor where the uterus becomes turned inside out, the fundus prolapsing through the cervix. The types are first degree, second degree, and third degree. Etiology includes spontaneous and iatrogenic. Iatrogenic causes include pulling the cord when the uterus is atonic and faulty technique in manual removal of placenta. Complication includes shock and hemorrhage. Oxytoxic and tocolytics. Oxytoxic are the drugs of varying chemical nature that have power to excite contraction of uterine muscles. Commonly used drugs are oxytocin or ergot derivatives and prostaglandins. They are mainly indicated to induce labor, to augment labor, prophylaxis to prevent excessive bleeding following labor, and for management of atonic PPH. Tocolytics are the group of drugs which used to prevent uterine contractions or to reduce the uterine contraction in case of premature uterine contractions. Commonly used drugs are magnesium sulfate, calcium channel blockers, indomethacin, and Dividlan. Lightening and quickening. Lightening 2 to 3 weeks before the onset of labor. The lower uterine segment expand and allow the fetal head to sink lower. It may engage. The fundus no longer crowds the lungs. Breathing is easier. Heart and stomach can function more easily, and women experience a relief from shortness of breath. Commonly seen in 36 to 38th week of primigravida, and for multigravida it occurs at the onset of labor. Quickening means it is the first and fetal movement pursued by the mother. It occurs around 18th week for a primate and 2 weeks earlier for a multigravida mother. Menorrhagia and metrorrhagia. Menorrhagia, it is a cyclic bleeding at normal intervals. The bleeding is either excessive in amount greater than 80 ml or duration is greater than 7 days or both. Common causes include dysfunctional uterine bleeding, fibroid uterus, adenomyosis, and chronic tubo-ovarian masses. The treatment directed to underlying pathology. Metrorrhagia, it is the irregular acyclic bleeding from the uterus. Amount of bleeding is variable. The main causes include submucous fibroid, uterine polyp, carcinoma of the cervix, and infections in the genital tract. Treatment directed to the underlying pathology. Malignancy is to be excluded prior to any definitive treatment. Cord presentation and cord prolapse. The cord prolapse means the cord is lying inside the vagina or outside the vulva following the rupture of membrane. The cord can be palpated directly by fingers and its pulsation can be felt if the fetus is alive. Management of protocol guided by whether the baby is alive or dead. Maturity of the baby and degree of dilatation of the cervix. If the immediate vaginal delivery is not possible, first aid measures like bladder filling, foster treatment, or replace the cord into the vagina to minimize the vasospasm. Cord presentation. The cord is shifted, slipped below the presenting part and felt lying in the intact bag of membrane. Diagnosis is made by feeling the pulsation of cord through the intact membrane. If the immediate vaginal delivery is not possible, cesarean delivery is the best method of delivery. False labor pain and true labor pain. True labor pain, the uterine contraction is always present, rarely exceeds 60 seconds, recur with the rhythmic irregularity, and then accompanied by abdominal tightening, discomfort or pain, are often accompanied by backache. Cervix is shortened, those is dilating progressively, membranes feel tense during the contraction, show is always present. False labor pain. Uterine contraction not always present, may last for 3 to 4 minutes, are erratic, may or may not be painful, not accompanied by backache. The cervix does not shorten progressively. There is no increase in dilatation. The membranes do not become tense. There is no shock. Ophthalmia neonatorum and asphyxia neonatorum. Ophthalmia neonatorum is the inflammation of the conjunctiva during the first month of life, mainly occurs due to chlamydia trachomatis. Management is by use of antibiotic. Asphyxia neonatorum is the non-establishment of satisfactory respiration at birth, occurs as a result of plasma insufficiency. Management is by resuscitation. Polyhydramnios and oligohydramnios. Polyhydramnios, the liquor amni exceeds 2000 ml. AFI is more than 24 cm. Abdomen is enlarged more than the period of gestation. The main causes include fetal structural malformations, multiple pregnancy, gestational diabetes mellitus, and chorioangioma of the placenta. The management is by amniocentesis. Oligohydramnios. Liquor amni is less than 200 ml. AFI is less than 5 cm. Size of abdomen is less than the period of gestation. Main causes include intrauterine growth restriction, postpartum pregnancy, premature rupture of membrane, and fetal chromosomal abnormality. Management is by amnioinfusion. Vesicovaginal fistula and urethrovaginal fistula. Vesicovaginal fistula is the communication between bladder and the vagina. Bladder and the vagina. They play the If the patient has no urge to pass urine, the urine escapes into the vagina, causing true incontinence. Urethro-vaginal fistula is the communication between the part or all of the urethra and vagina. Patient has an urge to pass urine. Urine dribbles out into the vagina during the act of maturation. Embryo and fetus. Embryo from 3 to 8 weeks after conception. The structures are not well differentiated. Length is measured in terms of crown drum length. The fetus. After 8 weeks of conception till birth, we call it as a fetus. Measures in terms of centimeters. Difference between abruptia placenta and placenta previa. Both are onset is in third trimester. Bleeding in abruptia may be concealed or it may be revealed or combined together. Placenta previa, mostly it is external, small to profuse in amount, bright red. Pain and uterine tenderness. In abruptia placenta, pain is always present, but in placenta previa there is no pain. Fetal heart rate. Abruptia, it may be irregular or absent, but in placenta previa it may be normal. Presenting part in abruptia may or may not be engaged, but in placenta previa it is not usually engaged. It is usually not engaged. Shock in abruptia placenta, moderate to severe depending upon the extent of concealed and external hemorrhage. Usually not in placenta previa. The shock is usually not present. Bleeding is excessive. Thank you for listening. If you have any doubts, please do comment me.